Welcome to another CTSNet Roundtable. My name is Elizabeth Stevens, a congenital cardiac surgeon at Mayo Clinic, and I'm delighted to be joined by several giants in the fields of adult cardiac and congenital cardiac surgery for the second in a series of 2 roundtables on what can adult and congenital surgeons learn from one another. The subject of the first session was mitral valve surgery, and the subject of this second session is tricuspid valve surgery. We hope this will be a thought-provoking session with broad appeal across our viewership. Today, I'm delighted to be joined by Dr. McCarthy, adult cardiac surgeon, executive director of the Bloom CV Institute at Northwestern Medicine in Chicago, Illinois, and Dr. Durrani, both congenital and adult cardiac surgeon, past chair of cardiac surgery and current director of pediatric and congenital heart surgery at Mayo Clinic in Rochester, Minnesota. Welcome to each of you, and thank you for being here. Let's start with Great, thank you. Let's start with what is the 1 or 2 most important techniques you learned from either adult or congenital cardiac surgeons regarding tricuspid valve repair.
So maybe I'll take that one first. Joe, good to see you again too, in our strange new world. One of these days again in person. I learned about how to do tricuspid valve surgery during my 6-month rotation with Gordon Danielson when I was at the Mayo Clinic back in my training in the 1980s. So what I learned from the congenital surgeons was really kind of at 30,000 feet. Number one is that he did right side surgery with the cross clamp off. And that to me actually kind of helped the time that when you're washing out the cardioplegia and kind of made the entire operation go faster. And I still do right-sided surgery that way. And as I'm putting the last stitch in the right atriotomy, we're weaning off cardiopulmonary bypass pretty much. So that was one thing that I learned. And the second was in those days in particular in the 80s, that Epstein was very challenging. And what I learned was don't give up. And there was a lot of steps to it. We were definitely on the steep part of the learning curve at that time. But those were the 2 big lessons that I learned then.
Great, Dr. Durrani?
Yeah, it's great, Pat, to hear some of your recollections with Dr. Danielson, who I think we both had the good fortune to overlap with. Things have changed a little bit now. I actually do very little tricuspid valve surgery with the cross clamp off, mostly because I found the leaflet tissue to be a little more fragile and delicate, and I find that it sometimes can be hard enough to have precise suture placement without sort of getting motion trauma and things tearing. But once the shunts are closed and the delicate parts of the operation are done, I do think allowing reperfusion, while you're doing stuff that's less critical, annuloplasty stitches or closing the atriotomy clearly makes sense. I think what I've learned from, I've had the good fortune of learning from both adult and congenital surgeons here. I think from the adult surgeons, what I've learned is to be more proactive with intervening on the tricuspid valve earlier on in the course, whether it's tricuspid regurgitation in isolation, or whether it's tricuspid regurgitation that's associated with left-sided heart disease. And I think that what I've learned from the cardiologists is that symptomatic right-sided heart failure is really challenging for them to manage. I mean, they start getting jacked up on diuretics, and their quality of life goes down. They start to get liver congestion. It really becomes a challenge for them. So earlier intervention on the tricuspid valve, I think I've appreciated from the adult surgeons. And I think from the congenital surgeons, because after I started on the staff, I visited a number of other congenital surgeons in China and in South America and in France. And I learned that the subvalvular interventions are much more critically important with the tricuspid valve than simply annular maneuvers. And so that is, I think, the way that I look at the tricuspid valve now, because the subvalvular apparatus is very different than the mitral. And I think that oftentimes you need to be doing things to compensate for an abnormal subvalvular apparatus, either increasing leaflet height or mobilizing papillary muscles, taking down attachments that allow much more mobility of the leaflets in the subvalvular apparatus. So I think that's what I've learned from my colleagues that are taking care of children as well as adults.
That's a great discussion. And we touched on Epstein anomaly. We've learned a lot about surgical repair of Epstein anomaly over the years. Are there any techniques for Epstein repair that apply to acquired tricuspid valve pathology? And maybe we'll start with Dr. Durini again for that one.
Well, I think, back to, I think what Dr. McCarthy was, referring to Dr. Danielson, Dr. Danielson did basically a monocusp type of repair where his objective was to get the anterior leaflet, which is the most generous of the three, to coap with the ventricular septum. And that works well for some patients, but once the right ventricle gets really enlarged, that is a difficult task to accomplish because the distance is so large that any of the maneuvers that you do to try to create that coaptation line is under so much tension that it's very vulnerable to dehiscence. So I think one of the things I learned mostly actually from Brazil, Dr. De Silva with the cone repair, is it makes much more sense to mobilize all of the leaflet tissue that you can and try to create a situation where leaflet tissue is coapting with leaflet tissue. So the degree of excursion of the leaflets becomes much less when you do that. And so there's less tension on the suture lines. And of course, leaflets touching leaflets is really the way that it was designed from the beginning. So to me, that is the most important principle, I think, of current repair techniques for Epstein, is trying to create circumferential leaflet tissue that you then sort of re-anchor relatively close to the atrioventricular groove, which is, typically not where things are located from the beginning before you start. So to me, that's what I've learned, I think mostly from Epstein surgery.
So it's been decades since I did Epstein's, but two of the things that you said resonated with me, Joe. And number one is, again, is sort of that referral pattern. And when you discuss the big dilated right ventricle and we're intervening so late on those patients, it's pretty typical in adults that we will see patients referred for isolated tricuspid surgery and their ventricle is really dilated, really big. It's really hard to get good coaptation of those leaflets in that case. And so we don't do the sort of same manipulation that you would need to do with an Epstein's, but we're very conscious about the size of the ring that we would put in there. And your earlier point about early intervention now with left side, it used to be controversial whether you would treat moderate tricuspid regurgitation, but now that's the standard of care. Now the controversy has gone on to more like mild. I don't know about the referral pattern for Epstein's these days, but I suspect that it is also moving to earlier intervention like we are in adults.
Yeah, I think that, sadly, it's such a rare anomaly that there's not a lot of surgeons that gain a lot of experience. So in principle, if you can, I think, provide a predictable, and reproducible operation, earlier intervention makes the most sense. But as you know, so many of these patients can do well and drift into the adult years and do quite well that if you don't have access to good surgery, you could make things worse by intervening and creating a problem, kinking a coronary or, creating arrhythmias from, aggressive resection or plication of the ventricle. So yes, in principle, earlier surgery would be the rationale, but I think it really is so dependent on what your surgical access is, from a team standpoint and an ICU standpoint, and obviously from a technical standpoint.
Great points. For years, the tricuspid valve was considered the forgotten valve and was often overlooked. As we've learned and acquired experience in mitral valve surgery, how has that impacted tricuspid valve surgery, whether that's operative techniques or you've touched on timing? Dr. McCarthy, do you want to start with that one?
Yeah, so I actually used to give a sort of a standard lecture about the tricuspid forgotten valve. And so as part of that, we were pulling out the number of publications about the tricuspid valve versus the mitral valve. And of course, the ratio is like 10 to 1 in favor of mitral valve. So interestingly, we revisited that about 2 or 3 years ago, and there's a lot more written about the tricuspid valve now. It's not nearly as forgotten. So people are paying a lot more attention to it. Now the forgotten valve is the pulmonic, by the way. We don't even bother to mention it. It's so forgotten. But the tricuspid, people are paying a lot more attention to. It shows up in the number of tricuspid valve repairs that is steadily rising through the STS database, and all the number of publications about things like risk factors for failure and different aspects of the technique of how to do tricuspid repair. So I think that we're doing much better with it. The failure rates are, in my world and the adult world, have to do typically with late referral, and in particular it's tethering. And so when the valve leaflet looks like this on echo, it's hard to get a small ring in there and to really get that to coap well. And so again, we don't see that quite as much as we used to about 15 years ago, which is a good thing. But that's still the one that worries me when I see that amount of tethering.
Yeah, I think I totally agree with that. I think that historically the results of tricuspid valve surgery have not been good, and so there's been some ambivalence and resistance on cardiologists to refer patients for tricuspid valve surgery, because when you look at many reports, the operative mortality could be as high as 10%. In some of the older series, it's even higher, and so it kind of got a bad rap. And so, but I think now, that conventional cardiac surgery has gotten so much safer, and I think intervening earlier is clearly to me the single most important thing. When they have leg edema and they have a creatinine of 2 and they got ascites and they have real class 4 heart failure, I mean, that's a problem. And even though we are more likely to consider surgery, I would be much happier doing it earlier on in the game. And for me, one of the things that I look for is the initiation of a diuretic. When a cardiologist is going to start adding a diuretic to their medical program, I think that should be a trigger to talk to a surgeon, because that means that they are now on the brink of really establishing clear heart failure. And that's when we want to be doing surgery at that point. And even before that, but clearly the diuretic is a trigger point for me.
Yeah, the evolution of intervention on the tricuspid really sort of follows the mitral valve, only it's decades behind. Again, when I trained at Mayo Clinic, the operative mortality for mitral surgery was so high, and it was because patients were referred when they were class 3 and 4 heart failure. Their ventricles were already distended and blown, and they didn't recover well. And now that has been sort of the typical pattern for isolated tricuspid surgery, but that's been improving. So go ahead, Elizabeth.
Oh, great. No, it's excellent discussion. I thought we could transition to some operative techniques and questions. So first, for maybe Dr. McCarthy, what is your systematic approach to examining and analyzing a tricuspid valve as you're trying to decide what you need to do?
So I do spend a fair amount of time looking at the echo. We don't have as good of images of the tricuspid valve as we do with the mitral valve. Getting a good 3D image of a tricuspid valve is a challenge for them. But I'm interested in the tricuspid annular dimension. I look at that amount of tethering. I don't have a specific formula, like if it is 10 millimeters below the annulus, that's too tethered. There are things like that for the mitral valve, but I just turn the color off and I just sort of look at it. When I actually examine the valve itself, I look for the amount of tricuspid annular dilatation and where it is. So of course, most of it is going to be at the anterior and posterior leaflet. And what I started to look at about 10 years ago is the commissure between the anterior and the posterior, and sometimes it really gets pulled apart. And there is a failure for tricuspid repair when they have really severe 4+ TR. And I think if we did better at seeing the jet, we would see that as some of those gaps like that. So about 10 years ago, I started closing that commissure between the anterior and the posterior if it was really severely dilated at that location. And then otherwise, we've talked about doing a patch to the anterior leaflet if there is quite a bit of tethering, to try to make that amount of coaptation better. I have to say I've done it multiple times and been, kind of it's okay, but it's not great. There was a randomized trial, and they pointed out that it is really tricky, as Joe mentioned, sewing into the base of the normal tricuspid valve. Those leaflets are really thin, and it's easy to get a tear or have problems there. And it added a lot of time, pump time when they were doing it. So if I see somebody, the older patient, I tend to replace it.
Great.
Well, we've had a chance to work together somewhat, Elizabeth, on these cases. So of course, the echo goes without saying. I'm really looking to see the height of the leaflets and whether there's any restricted motion to the subvalvular apparatus. So you examine that on the echo, and then when I start the operation, I put the cross clamp across the PA as well, open up the right atrium and fill up the ventricle and see exactly what is going on. And I do have a low threshold to detach the anterior leaflet and look, because oftentimes the anterior papillary muscle can have some fusion, to the anterior free wall. And just mobilizing that so that it's got more mobility will let that leading edge fall down even more. And sometimes there are other, muscular attachments like that just, it's very easy to just incise those. And then depending upon what the height of the anterior leaflet is, I look at the distance between the annulus and the leading edge. And I really like to see that distance to be at least twice what the width of the septal leaflet is. And if it's not, then before I close that, I just put an ellipse of autologous pericardium when I reattach the anterior leaflet. And ideally for me, I like to have the valve relatively competent before doing the annular reduction, because when you add the annular reduction, it's going to be really good and it's going to stabilize it. This commissure between the anterior and posterior and septal, there's oftentimes gaps there, and there can even be one at the between the septal leaflet and the anterior leaflet, and those clearly, as Dr. McCarthy said, need to be closed. And so that's at least, my approach. I use small bands. I use flexible bands. We can have Dr. McCarthy talk about, about his approach to bands. I use a flexible band for the following reasons, and it goes from the anteroseptal commissure clockwise to the coronary sinus. It does not come all the way around the septal part of the annulus. It goes down. The last stitch is anchored with a pledget in the coronary sinus. And I use a 26 ring or a 28. If the patient's over 100 kilograms, I use a 28. If they're less, I use a 26. I like a flexible band because if you look at the earlier studies of the shape of the tricuspid valve annulus during systole and diastole, it's like a saddle, and the saddle changes its shape during the cardiac cycle. And we've noticed in the Epstein patients, because we have a fair number of them over the years that had replacement, that as soon as you do a replacement and you put patients side by side where their RV function is comparable, the RV function takes a nosedive. And I'm convinced that it's because the annulus is fixed in one plane, and it really affects the whole, the systolic function of the right ventricle. So that's the reason I use a flexible band. But I know that Dr. McCarthy's got a lot of experience with bands, and it would be helpful to hear your analysis of this.
Yeah, so over the years, my experience evolved. It used to be the DeVega way back in the 80s and early 90s. And then I used the Cosgrove band for many years when I was at the Cleveland Clinic. I saw a lot of cardiomyopathy patients that I was treating. And so what worried me was that I was starting to see moderate TR in that group of patients with even with a small Cosgrove band. And part of that clearly would have also been the tethering issue. So I went to the classic Carpentier ring for a while, but it dehisces at the septum. And so I started bending the ring, and eventually I invented, by way of disclosure, the Edwards MC3 ring. Therefore, obviously I'm biased, Joe. But I think it fits the shape of the annulus very well. Unlike a replacement, I don't think that it impacts the function very well or very much. And the results from Cleveland Clinic afterwards and all the more rigid rings do well. Now, having said that, it was 20 years ago that I invented that. I would do another one that was more flexible. But I still like that idea of really kind of fixing that shape. The bands can kind of bend a little bit. They can become an abnormal shape.
Mhm.
Great. Well, let's move on to the use of artificial cords. Are there any similarities or differences when you think about when you need to use cords for the tricuspid compared to the mitral, or how you approach that? Dr. Drain, do you want to start with that one?
Sure. Well, we have a lot of experience with cords with both of the valves. The mitral is very different. The subvalvular apparatus goes down to two papillary muscles, so the shape of the subvalvular apparatus is much more like a parachute with the cords coming down, drawing the edges of the leaflet together, where the tricuspid is not like that. There are three major papillary muscles, but there are a whole bunch of cords that go directly into the ventricle all the way around it. And so what happens when you get tricuspid regurgitation and RV dilation is the right ventricle changes from a crescent shape to a circle shape. And as it gets dilated, it just drags the leading edges of the valve away from each other, which is why just doing an annuloplasty alone doesn't always work. You make the annulus smaller, but the leaflet edges are being dragged up toward the ventricle because of the RV dilation. So when I put artificial cords in, and most of the time it's to the anterior leaflet, occasionally septal, but mostly anterior, I anchor the cords in trabeculations in the septum. I do not go to papillary muscles because it's very difficult to gauge the length of a cord to the papillary muscles in the tricuspid because it's so dependent on the size of the right ventricle, where anchoring it to the ventricular septum in trabeculations down toward the apex, it does two things. First, it's much easier to determine the length of the cord. And number two, it naturally draws the leading edge of the anterior leaflet down toward the septum or the septal leaflet. So the cords for me, we've described this, we've written about it. They go down to ideally trabeculations in the ventricular septum, below the cords of the tricuspid valve. I usually use 5-0. If it's an adult, I'll use 6-0 if it's a child, although in a child it's not necessary to do so very often, in contrast to 4-0 Gore-Tex cords, which we would use for the mitral on the left side. So that's at least what I do.
So I think they're actually pretty rare in adult tricuspid surgery, most of which is functional TR. When we do see a patient that has prolapse, and you're looking for analogies to the mitral valve, it's usually not a flail, it's just prolapse. And even at Cleveland Clinic years ago, we published that if you have just prolapse of the anterior leaflet with bileaflet disease, once you put a ring in there, the leaflet is going to hit the posterior leaflet. And so you're going to eliminate the mitral regurgitation. And I think in the unusual case where we have prolapse of the tricuspid valve, it's similar. The concern I have about artificial cords with the tricuspid, besides that most people don't have the skill of Joe and get that length right, is that the ventricle can remodel over time. And so if you are operating on a patient and the ventricle is dilated and you put in cords, it may look great until about a year later when your ventricle is, now smaller, it's remodeled. So in general, we've avoided them.
That just to make a technical point, that is the advantage of not going to the free walls of the ventricle, is it's less vulnerable to changes with remodeling, because the distance between the leading edge of the leaflet and where it's going in the septum, that distance is not likely to be altered that much with remodeling, as opposed to the anterior and inferior walls, which are the ones that are going to be doing most of the shrinking down.
So Joe, do you do that in the adults too? Like if you were doing a mitral tricuspid, would you put cords in?
No, I only put cords if there's a flail segment, or if there's severe prolapse. I do. I mean, to your point, I mean, when you do an annuloplasty, you'll get coaptation. But if I see the anterior leaflet really billowing up and that leading edge is getting like it's almost starting to override the septal leaflet,
Okay.
I put the cord in there just to I don't know. We've had good luck with it,
Yeah.
and I think there's little to lose by doing it, and there's potentially something to gain. But you do the sizing of them is the hardest thing about it than the right side.
Yeah, I assumed when you were talking about the septal, I thought maybe you were getting at that point about the regular remodeling.
Yeah.
Great. Well, we talked about this a little bit earlier, but maybe it'd be good to revisit. Dr. McCarthy, you were talking about when to intervene on the tricuspid when it's not your primary indication. So in other words, you're there for mitral surgery and you're looking at the tricuspid, and you touched on that, but maybe you can elaborate on at what's your threshold when you're there for another reason for cardiac surgery and there's concern about the tricuspid.
Yeah, so it's pretty much 100% now if patient has moderate tricuspid regurgitation. There's all the classic ones, so that if a patient has in the past had more tricuspid regurgitation, even though it may have resolved by the time you're in the OR, you should still assume that that could recur. Anyone with a history of right heart failure, edema, ascites, and all, I would always treat that. We just published in JTCVS the tricuspid annular diameter. The guidelines say 40. I actually measure it and record it in all of our patients, and we really didn't see any recurrence until it got to 45. So 40, I think they kind of pulled out of thin air, and we thought 45 was more reasonable. The one that's really kind of interesting that we found in that paper I just mentioned was atrial fib. And the patients that had a history of atrial fib were much more likely to develop moderate tricuspid regurg over time. And so that has me now thinking, if I'm there and I'm doing a maze, and even though it may only be mild TR and all, I may put a ring on in that group of patients just to stabilize it. It's probably atrial functional tricuspid regurg that may develop in that group.
Right, Dr.
Yeah.
Johnson?
Yeah, as you know, I'm very aggressive with the tricuspid valve because many of them, I see so many of the patients that I just want to try to reduce the cumulative number. So for me, the indications are and this is an important point, the decision to intervene needs to be made before you go to the operating room, because the conditions of anesthesia will talk you out of doing a lot of things to the tricuspid valve because it always looks better. So you don't want to wait till the operating room to make that decision. So if they have moderate TR, I'm going to go after it. If the annulus is 40 millimeters, I go after it. If they have elevated pulmonary artery pressures, I go after it. If they have a left-sided lesion that is going to be vulnerable to recurrent disease, I go after it. If it's pulmonary valve disease, I have a really low threshold to do it because pulmonary valve problems are going to develop sometime down the road. And if you are preemptive, you may delay the next intervention if you can preserve some element of competency of the tricuspid valve. I will say that I will oftentimes do a purse string annuloplasty if we're talking about mild plus TR and not make the decision to do a band. I pretty much always use a band if the indication for surgery is TR or if they have pulmonary hypertension. But if somebody's got myxomatous mitral valve disease and their annulus is 40 millimeters and they have mild TR, I'm more inclined to do a purse string annuloplasty and keep it simple. I don't know whether that's right or wrong. I know Dr. Schaff has made the point that, if you know how to do a purse string annuloplasty properly, there's no difference in reoperation, whether it's banded or purse stringed. And I don't always agree with that because a lot of these papers use the endpoint of intervention. And the problem is that we drag our feet with the reintervention. And there's a lot of people that are walking around with important TR that are now back on a diuretic and so on and so forth. And to me, I consider that a failure. If they require medical therapy for TR, then we miss the boat, so reintervention is a bad endpoint, in my opinion. I think you're shaking your head, Patty. I think you probably agree.
Yeah. Yeah, no, we definitely underestimate if we use reintervention, and the mortality for patients that have had tricuspid surgery and then need a second tricuspid procedure is extremely high. So all of those are going to transcatheter these days, if at all possible.
I think the one group we didn't talk about, which we don't see as often here, is the rheumatics. I think you should be very proactive with rheumatics, because they're just a setup for chronic valve problems. They're setups for, pulmonary hypertension. And I think the threshold should be really low. It just adds so little to the operation to do it while you're there. And in my experience, the mistake is leaving it alone more often than it is going after it. And if it was one take-home message I would say to the audience, I would say err on the side of being proactive with the tricuspid valve. We could argue whether it's 40 or 45, but make an algorithm in your practice and stick to it. And be more aggressive rather than, passive, because I do think it's an important source of problems for patients, and it's a challenge for the cardiologist, once they're dealing with it.
And keep your distance from the conduction system, because you don't want to have that tricuspid and then they need a pacemaker and now they have a wire going across your freshly repaired valve. So that's bad.
Speaking of pacemakers, maybe Dr. McCarthy, do you want to talk a little bit about how you deal with lead-induced TR or
Sure.
even, angular dilation in the setting of having a lead already across it?
Yeah, so, first of all, I just look and inspect the pacemaker, and a lot of times it's actually there and it just happens to be there. There's functional tricuspid regurg. But what I'll do is I'll push that pacemaker then down into the commissure between the septal and the posterior leaflet and take a couple of 5-0 ethibond sutures and just push it all the way down so that it is essentially out of the flow, and it can't get into any mischief anymore, I guess you would say, with that. If they actually have the wire going through the leaflet or pinning the leaflet, then that's more complex. Then I'll end up freeing up the leaflet by sharp dissection and then try to increase the mobility of the leaflet, and then again push it into the commissure and then secure it that way. There's an occasional one where it's just really a bad actor and we may remove it, and then put in epicardial wires, or occasionally we may end up having to replace because of the amount of damage in the clinical situation if it's a 7-year-old patient, that sort of a thing.
Sure.
My approach is very similar. There's maybe a couple minor differences. I actually will put the lead at whichever commissure it seems like it most naturally wants to lie, depending upon how it's going through the valve. Most of the time, it's what Dr. McCarthy said, it's usually between the posterior and the septal leaflet. And if I have a choice, that's where I would put it. But sometimes it lies more naturally at the anteroseptal commissure, and occasionally, probably least likely, up by the anterior and septal leaflet. Now, if it's entangled in the cords, what I have done is incise the leaflet from the lead to the annulus and mobilize the lead as much as I can, and then move the lead to the annulus and sew the leaflet, up to the lead, so that it's actually not at a commissure, but it's up against the free wall of the ventricle, so it minimizes reduction of excursion of the leaflet. Now, that requires that it not be too entangled in the cords, otherwise it will restrict it anyway. And I think as Dr. McCarthy said, if you really have a bad actor, you need to take it out. And I think the one point that I would make is that if it's a young patient, I would do whatever you need to do to repair the tricuspid valve. And if that means abandoning the lead and putting an epicardial pacemaker in, that's what I would do to get a good tricuspid valve repair. Because to me, I think that is the more important thing in the long term. And for a young patient, not having a lead in the bloodstream may be a better strategy anyway, even though the thresholds may be not as ideal. The steroid-eluting electrodes are pretty good these days, and I would probably err on the side of a really good valve repair and remove the lead and convert to an epicardial pacemaker in a younger person, whereas a 77-year-old, I probably would, I would not go to that extreme. What do you think, Pat?
I agree with that. And if I am replacing in an older patient, I may just leave the lead in place and then
Yeah.
just replace around it. And so it's under the sewing ring.
Yeah.
Mayo is one of the only places that ever published a paper that I thought was really interesting. If a patient has a bioprosthetic valve and then you have to place a wire through it, the durability of the valve actually wasn't damaged.
Yeah.
That came out about 8-10 years ago. I was actually surprised and happy to see that.
Well, I think one of the, because I know that some of my patients are that I think the one point to make about that is that if you're going to do that, the pacemaker people need to do it with TEE guidance, because you want the lead to fall into a recess between the bioprosthetic cusps, and they can tell that right away when they're doing TEE, because if it's pinning one of the leaflets open, there's a lot of TR, and they just have to manipulate it a little bit till it falls in a recess. That's why it works, and that would be my strong suggestion, is to encourage them to do it with TEE guidance so that they optimize that.
That's like us putting it in the commissure.
Exactly.
In a place where a location where it won't cause much damage.
Right.
Well, maybe one more question before we close, mostly for Dr. Durrani. How does a patient who's had a previous complete AV canal repair change your management of tricuspid valve surgery?
Well, I think the general principle of paying attention to the tricuspid valve when you have a mitral valve problem, which is the more common problem with AV canal, still stands. You got to honor that principle. I think that I'm aggressive with the tricuspid valve. I think you have to be more careful of the conduction tissue. You can't get carried away down by the coronary sinus, because the conduction tissue is displaced close to the coronary sinus. I would still do the same kinds of things. If there's, with an AV canal, there's more likely to be sort of some natural cleft-like abnormalities that you might close, but I would still use a band. I would still use a smaller band. I would still, use the indications for surgery the same, dilated annulus, elevated pulmonary artery pressures. It's actually not a difficult valve to, repair, because there's usually a fair amount of leaflet tissue. And just make sure that you deal with the left-sided AV valve, because otherwise you're going to just leave a substrate behind that's going to perpetuate TR. But I mean, that's, what I, would do.
Well,
Pat?
we're drawing close. Yes, Dr. McCarthy, any other comments?
So I have to admit, if they've had their AV canal already repaired, when I see them, it's usually about their mitral valve, and I'm there. And one thing that I run into is that sometimes gets pretty calcified, like 30, 40, 50 years later. But I honestly can't remember Elizabeth having to do a tricuspid in one of those patients, but I think they all go up to Joe. So
well, any further closing comments from either of you? Thank you for such a great discussion.
I think my only comment out of the adult world is that transcatheter is really having a big impact, probably much more than in congenital. It's been interesting how much better we can enroll in the tricuspid trials than we can in some of the percutaneous mitral trials. And I think it just speaks to this is a problem that was under-recognized, is delayed treatment, and these are patients being referred really late with liver dysfunction and renal dysfunction and torrential tricuspid regurgitation. So hopefully having a transcatheter approach will help all of us and increase awareness and earlier referrals.
Yeah, I would think that's a good point. I would just say that we should I think percutaneous approaches for the tricuspid on the whole are going to be much less likely to be successful. I mean, I think actually the tricuspid valve in many ways is a harder valve to repair than the mitral.
I agree.
For all sorts of reasons. I think both anatomic and physiologic, and ventricular issues. And so I think that we just need to be cautious about applying any percutaneous strategies in the tricuspid for somebody who is otherwise young, who is a good candidate for surgery, because we will invariably burn a very bad bridge, in terms of not being able to repair it when it doesn't work and they do come to the operating room. So I think that's just something to keep in mind. There's a lot of enthusiasm early on with this technology, but I think it's less likely to be successful in the tricuspid just because of the anatomy of the leaflets and the problem with the RV dilation and the subvalvular apparatus and all the things we've been talking about now for the last 30 minutes. We should just be cautious in patients who are good operative candidates about exposing them to that when they're more likely to get a good operation.
I agree, and I'm sure that the edge to edge, the transcatheter edge to edge type approaches are going to destroy those valves. So that if we did have to operate on them, we'll probably have to replace all of those, which is basically what we have to do in the mitral too. So, but I think it'll increase awareness. And,
it'll increase
and
awareness.
actually, so since we have an active transcatheter tricuspid, we're actually seeing some young patients get referred earlier for transcatheter treatment, and we say, no, you should have surgery. And that's helped.
There's technology for percutaneous annuloplasty strategies with the tricuspid that I'm very aware of. And I think the one difference between this and the mitral is the right coronary artery will be much more vulnerable to problems on the right side, and there's going to need to be a lot of caution with that. And it'll be right at the crux of the heart, right where the posterolateral PDA is coming off, just down there in the area of the coronary sinus. And I think that the interventional cardiologists, they're not dialed into that quite yet. And they're going to, when they have a few problems, it'll be a wake up call. But the right coronary is so vulnerable to problems with tricuspid valve annular reduction maneuvers that everybody, whoever's doing stuff with the tricuspid, really needs to be paying attention to that.
Yep, agreed.
Well, with that, I'd like to extend a special thanks to each of you for spending your time with us and sharing your expertise. We really appreciate that. I would also like to thank CTSNet for providing this opportunity. Thank you so much.
Thanks, Dr. Stevens. And Pat, thank you. It was great catching up with you and hearing your insights.
You too, Joe. We're looking forward to doing it in person next time.
We'll do it. See ya.
See ya.
Elizabeth, thank you.
You're welcome.
Thanks,
Bye,
Catherine.
Elizabeth.